First of all, I'd like to thank the brand new Nova Scotia College for the invitation to speak today. I'd like to offer my sincere congratulations. 2020 has been primarily a year that most of us would like to forget, but 2020 will also mark an incredibly important year for medical imaging and radiation professionals in Nova Scotia and for the patients and society that you serve. So now for my talk. Much of my research interest over the recent years has been in how professions adapt to disruptive technologies, and so I came by studying AI quite honestly. My focus is not on the technical specifics of AI as a technology, and so I'll give you that disclaimer there, but rather on its impact on our professions. So I'd like to start by reading an excerpt from an article, this article here published a year ago, September. So recognition of the powerful pattern matching ability of humans is growing. As a result, humans are increasingly being deployed to make decisions that affect the well-being of other humans. We are starting to see the use of human decision makers in courts, in university admissions offices, in loan application departments, and in recruitment. Soon, humans will be the primary gateway to many core services. The use of humans undoubtedly comes with benefits relative to the data-derived algorithms that we have used in the past. The human ability to spot anomalies that are missed by our rigid algorithms is unparalleled. A human decision maker also allows us to hold someone accountable for their decisions. However, the replacement of algorithms with a powerful technology in the form of the human brain is not without risks. Before humans become the standard way in which we make decisions, we need to consider the risks and ensure implementation of human decision-making systems does not cause widespread harm. So the article then goes on to talk about the need to avoid inherent bias of humans, the lack of transparency of decision-making, inconsistency in decisions, and their inefficiency in being fit for purpose. So this is clearly a tongue-in-cheek piece that is flipping our standard concerns about technology on their head and making us reflect on the fact that of the many things we're worried about with technology are inherent to humans as well. So why is it okay for us to have these faults and we're tolerant of those, but we use them as an argument not to be replaced by technology that has similar faults? So keep this concept in your head as we go through the talk today. So over the next hour, I hope to make you feel more comfortable with AI as a hot topic, both in society and in your professional work. I'll cover some of the foundational principles and terminology in AI, as well as some examples of where it is being explored and applied in healthcare. I'll follow with some of the challenges we face in implementing it, and that's really the focus of my work: regulatory, ethical, professional, and educational. Overall, I hope that I can convey where AI may have an impact on practice and how we do ourselves a disservice if we keep our heads in the sand. So the sheer volume of technical jargon, abstract concepts, and futuristic hype around AI make it a daunting space to wade into. Most of us have a general picture of things like big data, automation, but we steer clear of scary words like autonomous neural networks or blockchain. In fact, even for those of us who have a good grasp of these concepts, and I think I have a decent one, it's actually hard to decide what fits under the umbrella of artificial intelligence and what might be sort of adjacent to it. So I'm just going to give us a quick primer over the next few slides. So despite some of these challenges in really nailing down a definition, there really is a clear place to start and a strategic way to organize our thinking in this space. So there's one definition here, but essentially AI is the receiving of signals from the environment and performing actions based on those signals. In other words, AI involves responding to incoming data in what would be considered a rational way that is informed by that data. So based on that definition, I can assign the rest of the terms and concepts as being related to either the input to the system or the data, the process or the method of dealing with that data, the manipulation, and finally the output of the system or what the machine spits out. So let's start with the data, the input. Big data is a term that is given to the massive data sets that would be unwieldy for us as humans to manage, relying on modern computational power to reveal the patterns. And that's really why AI has been able to take off in recent years. In any discussion of the nature of big data, you'll hear about the V's. So while there were originally 4 V's, they seem to be just adding V's left, right, and the center all the time. But we're going to stick here with the 4 original V's: volume, variety, velocity, and veracity. So volume is really the easy one. It's the immense scale of data that's available to us that's way beyond human capacity to be able to harness its potential. It's said that by sometime this year, 300 times the amount of data will exist than existed in 2005, so only 15 years ago. Variety then is the different forms of data, from social media data to wearable devices to healthcare data to video data, etc. Velocity is then the speed at which that data can be created, streamed, and analyzed. So how we can work with it and how quickly we can work with it. And finally, veracity, or truth. So that's the uncertainty of data or its quality, the degree to which the data that we see can be trusted as being accurate. So another concept very relevant to healthcare data in particular is the idea of structured versus unstructured data. Structured data is that can be readily displayed in a database: numbers, dates, data strings, etc. But this represents only about 20% of data, and it's pretty easy to store. Unstructured data is everything else, pretty much anything we deal with in healthcare. Images such as medical images, audio, text files, so dictated reports or records, lab volumes, emails, anything like that. This requires more storage and is really unwieldy to manage. So now that we've covered the nature and the characteristics of data, there's the process or method of manipulating it to enact some sort of response or output. So that's this middle piece here. For some aspects of AI, this is pretty straightforward, such as a monitoring device like a Fitbit, transmitting data to a receiver. But in the area of machine learning, it warrants some more discussion. So this is where some of the scary terms start to come up. We use a lot of them sort of interchangeably, and really in lay terms, that's probably okay. But in fact, a lot of these are distinguished along a continuum or in the sort of nesting categories like here. So this is an important one. If we see AI as the broader category of enacting a rational response from input data, so this term was coined in the 1950s, machine learning is the next layer that came along a little while later, a process by which a machine can actually improve its performance or learn based on new data. So as new data is fed into the system, it can actually improve its response, its learning. Deep learning is then a slightly more nuanced beast, but it's basically differentiated just by the complexity of how data is systematically crunched across many layers of decisions. So an example of this is autonomous neural networks, which work in a way that's sort of analogous to the human brain, the neural layers of the human brain, in that one layer can be activated if it reaches a certain threshold, and then it stimulates the next layer to sort of make a decision or enact a response. So these are respectively here, this is the next level, are known as supervised and unsupervised learning. So with supervised learning, in the orange on the left there, we have our input pictures of animals. We give the system that input data, so those animals, and we then tell it what the desired output is. So we have our input picture of animals as well as our desired output, which is that we want to know whether it is a duck. So once we've fed it enough data, we tell it with each input data what is a duck and what is not a duck. And after we feed it enough data, it starts to learn. So it knows, okay, the ducks are the ones that are these blobs with a little orange blob on the front and then these little sticky orange things that come out the bottom. And so it learns that those are ducks. Once it meets the designated expectations for performance, so that we routinely, as we feed in a duck, it knows that it's a duck, it can be used as a predictive model where we can feed new data in and not actually label it as a duck or not, and the machine can figure that out for us. For unsupervised learning, we don't tell it anything at all. We just feed it a bunch of pictures and the machine clusters things based on common characteristics. So it doesn't know that it's looking for a duck, but it still sees those same characteristics of the blob with the little orange sticky things, and it'll cluster them together. So it's up to the user to then go in and make sense of that and say, okay, well, these ones up here are the ducks and these ones over here are the bunnies or whatever they are. But we don't actually know which characteristics it's choosing in either system in order to categorize them the way it does. A human can then go and manage all of this on the outset in both supervised and unsupervised and deal with the decision that is made. But on the right, the unsupervised learning, this is where the idea of the black box comes in that we actually don't know how it's clustering those things, and we can go in and make sense of it, and hopefully the categories make sense, but we actually don't know what characters it's making use of. So that's a little bit about the various ways in which the data can be manipulated. But finally, we have the nature of the output of the system. In many cases, the action or the output is dependent on the intended use. As well as the output of machine learning, as we've just discussed, there are many other outcomes and thus purposes of AI. So it should be noted that these are not all necessarily mutually exclusive. So many of the things here, even though one of them is clearly listed as machine learning, actually do involve machine learning. Things like natural language processing, optimization strategies, computer vision, and aspects of robotics, and even the Internet of Things that are all included here under the broader AI umbrella. So that's really just a quick run through. I hope it hit the spot. This is not really a talk about all the technical aspects of AI, but just to paint you a picture of the foundational elements to allow us to make use of these examples that I'm going to provide. So these are not all necessarily the biggest and brightest examples of healthcare AI, but rather I chose a series of very academic papers on various topics, both within radiation medicine and not, so we can have our minds open to the potential of AI. So watch for some commonalities as we go through these. First, there's the reliance on and the output of massive amounts of data. So we need data, and then we will also be given data to make use of AI. Then there's the focus of offloading very rule-based decisions. So if a decision can be broken down into a set of rules or layers to guide decisions, then it can be readily managed by a machine, probably more quickly and accurately than a human could do. Finally, there's the concept of monitoring, or the use of data to artificially keep tabs on something, providing an alert if it deviates from sort of an accepted threshold. So I'm going to start with a few radiation therapy examples. This investigation used a Turing test to compare expert physician-generated contours to machine-generated contours. So the Turing test is basically a test of the indistinguishability of a human from a machine. So if someone blinded me to the origin of a contour, so if I'm given a contour and no one told me whether it was produced by a human or a machine, if I'm not able to tell whether it was done by a human or a machine, then that's a pretty good sign that the machine is doing a decent job and is of somewhat equivalent to a human in performance. So that you can see here the results for a series of organs of risk that were contoured. So blue is where the blinded participant guessed correctly as to whether the contour was generated by a human or a machine. Red is where they guessed incorrectly. So the pies are the overall results, and then the bars below are sort of the more complicated thing about dividing them by their guesses where the origin was human versus where the origin was the machine. So you can see that the guesses were pretty much 50-50 for everything but the esophagus and the heart, meaning that there was no real way for us to discern or be correct or incorrect for most things except the esophagus and the heart. If you look at something like lung, sure, I could probably contour the lung pretty well. So there's not quite as much nuance and skill required to do some of those as there might be for the esophagus or the heart. Also, interestingly, in almost all cases, discernibility for the plans done by the machine was higher. So we were more likely to guess correctly if it was ultimately the machine that did the contour. So often this might be explained by the fact that when the machine gets it wrong, it gets it very, wrong. So whereas a human might make sort of a little blip here and someone might disagree with them and do it here, often when the machine gets it wrong, it is so blatantly wrong, like that they contoured the wrong organ entirely, rather than that we just aren't sure about decisions they made about one slice of the heart, for example. So this report also acknowledged the time savings. You can see that on the right, and having an expert manually edit contours made by a machine. So never do we just accept the contours made by a machine, but how much time could we save if the machine did it and we just verified that they were done correctly? So the physics resident who sent me this paper actually also noted that there's a website, and you can see it on the right there, where you can log in and participate in this Turing test. It'll give you a contour and you have to guess whether it was done by the human or the machine. So that same physics resident was involved in this project. So she's now staff at Princess Margaret Cancer Center. Her name is Lee Conroy. She did this work at Princess Margaret with Chris McIntosh under the guidance of, on the supervision of Tom Purdy. So using a prostate planning algorithm and a training data set of 74 therapist-derived plans. So that's those 74 ducks that were fed into it and labeled as ducks. They created a planning algorithm. They then took 17 other previously treated plans that already, so they already had a human generated plan for them, and they then allowed the machine to create a new plan. The original therapist plan and the algorithm plan were then given to 2 oncologists and a physicist, essentially to undergo peer review. They were blinded, so they were given the therapist one and the machine one, and said, which one would you choose for treatment, not knowing who or what had created each one. So as you can see here, the vast majority of the oncologists and physicists preferred the automated plan. And actually, ultimately, in 12 out of 17 cases, if this had undergone a regular sort of peer review and approval process, in 12 out of 17 cases, the machine-generated plan would have been selected for treatment. So this was a retrospective study, and we actually couldn't make that decision for treatment. But since this work, we've gone into round 2, where this was done prospectively. We took a new CT simulation and had a human planet and a machine planet, and then they both went through peer review, and the preferred plan was chosen. Sorry, you'll see my cat is joining us for the talk. It's the benefits of working from home. So that's the 2 radiation therapy examples, and I'm sure many of you have others on your radar that you've heard about or you know about, mostly relating to treatment planning or to machine QC activities, or maybe even to big data and such things as patient-reported outcomes. But in the grand scheme of things, if we limit our thinking to applications of AI strictly within radiation medicine, we miss out on the massive opportunity in research and development that is going on beyond that in other areas of healthcare, other areas of society. So there's a lot of other things going on that could then be brought in and applied to radiation medicine. So I'm now going to step away from the radiation therapy examples to highlight a couple of other examples in healthcare, and I'll leave it to you to sort of connect the dots as to how this could then apply for us. So many of you may have heard of this example. It's quite a well-known one in dermatology. So this was published a few years ago. This article reports on the development of an app that can diagnose skin cancer. So essentially, you can use your iPhone and you can take a picture of that mole that's been worrying you on your arm, and it will tell you whether your concern is justified. So the figure here is of the neural network, or the machine learning, that employed unstructured data. So images are by nature unstructured data. It took 130,000 images of skin lesions. So it tagged them manually. So humans labeled them as being either benign or malignant according to a number of different diagnoses and aspects of the skin condition. So that would be sort of labeled or supervised learning. And that was used to generate an algorithm to learn how to categorize a new image presented to the trained system. So as a new picture is then fed in, the system looks for patterns across those 130,000 images that it's already seen and compares them against that existing bank. So this algorithm performs with fantastic accuracy. In this study, it performed on par with 21 expert dermatologists. And of course, this is getting better and better as each new image is fed in. So essentially crowdsourced, as I take a picture of my mole and I feed that into the system, it gets better and better. So it's very similar to related progress in radiology, ophthalmology, and pathology, for example. This article relates to the Internet of Medical Things. So that's sort of the classification of our various devices that we might use for that could be considered monitoring devices. So imagine being able to equip patients requiring complex care with devices that could monitor them in such a way as to be able to allow them to stay at home rather than being admitted to hospitals. So of course, in the times of COVID, being able to allow someone to stay at home rather than being an inpatient is a huge advantage. So this article focuses on people with complications from diabetes and the ability to monitor insulin levels, activity, lower extremity blood perfusion, and other relevant factors remotely. So they have monitoring devices that can manage all of these things. Programming the system to alert a responsible healthcare provided, perhaps in the hospital or in primary care, if any one of those metrics or levels goes out of tolerance, or even if it's heading out of tolerance and we need to warn the patient to do something differently. So such a system could also include medication reminders, direct patient interaction through video conferencing, and other mechanisms to support patient autonomy. So this kind of smart home solution has been used to explore such areas as cardiac and palliative patients, as well as those with dementia, in other circumstances where the traditional solution would have been inpatient care. So this is Pepper. So Pepper delves into a space of great debate and yet is becoming quite popular. I actually ran into Pepper a few years ago at the Montreal airport wearing a Habs jersey. So this delves into the area of artificial empathy, let's call it. Pepper is a humanoid robot developed in Japan. She's programmed to recognize human emotions through facial expressions, mannerisms, language, things like that she can sense through various sensors and cameras on the robot. She then finds patterns in these signals and effects a very calculated response. So while initially this was marketed as a sort of personal assistant type tool, she's increasingly used in healthcare for a range of roles, from hospital greeter to sitting with elderly or unwell patients as a comforting and reassuring presence. So while that might not sit well with many of us, and in fact, many articles have been written about artificial intelligence and empathy, but if we imagine us again in this COVID world where humans can't be present in these kinds of situations, or the humans that are there are being run ragged, running around the wards, maybe this is an option for us. So this paper now is an example of an optimization model. It was designed to offload the task of manually scheduling a chemotherapy department. A series of objectives were fed into a system. So the idea of minimizing wait times and nursing overtime, prioritizing that the same patient work with the same nurse as often as possible, and that complex care be managed by the nurses with greatest experience, and then that we can manage the patient mix based on their available resources each day. So these various objectives were fed in, and the data was crunched in various ways using the computing power of the system, not unlike IMRT in dealing with multiple objectives and then just running through multiple iterations until we have something ideal. So obviously better than any sort of Excel file or paper management system that a nurse or a scheduler or clerical staff could manage. And finally, this paper reported on the use of machine learning to predict outcomes of children presenting to the emergency room. So to train its system, it fed in data on 52,000 nationally representative ER visits, considering only the information that would have been available at the time of arrival to the ER. So things like the patient's age, how they are presenting symptoms, vital signs, how they arrived at the hospital. Some of this data might already traditionally have been collected by triage nurses, for example, but others might be factors that people just didn't think were relevant and never collected, such as the mode of arrival at the ER. But if you look here, the reference model, so that's the triage, the manual triaging system that the nurses were already using in this department, all the other algorithms that were tested were at least marginally better than that reference model in predicting outcome based on presenting characteristics. So it was reported here that this model could then be used to reduce the under triaging of critically ill children. So when I was approached about giving this talk, I started to think about the ways in which AI could impact our practice. I'd envisioned considering a bit of a day in the life of a therapist in an AI-enabled world, but that seemed like a bit too much. So instead, just a little blue sky exercise as to how these AI could change the skills, competencies, roles, and interactions of the therapist. So just pay attention to some of these examples and think about what that would do for our practice, our workflow, and our patients. But before I jump into the highlights, there are just two caveats. First is that many of these technology solutions or concepts are already possible, but money has just been our biggest barrier, or even willingness to try them. And finally, we have to assume that things like cybersecurity or big brother-like surveillance or all these other reasons for not delving into some of this data are a non-issue. So imagine that we would no longer need to conduct machine quality control every morning. It's still important that QC be done and that we be present to oversee it, given that we're nuclear energy workers, but the press of a button can set into action an automated series of tests with the system alerting us and accelerator services personnel if anything is out of tolerance, or even if anything is heading out of tolerance, so we can actually catch it before it gets there. So another example is, imagine that we no longer need to waste all of our precious patient interaction time on scheduling. So just as you saw in that chemotherapy example, 90% of patient appointment queries are rule-based and can be addressed through a sort of rule-based self-serve scheduling system. You put in a couple of rules and parameters that each patient sort of has the option of, and it's only those requests that cannot be easily resolved that are flagged for our expertise and our intervention to see if we can solve a given situation. So now imagine a CNS patient, and this is the patient population that I worked with primarily. Expected to lose patches of hair at some point in her treatment. This was a common question that we would get on day one for many patients. The record and verify system will now notify us in real time when specific volumes of a patient's scalp have reached the threshold dose. We can then notify her and actually show her in the system the affected area of her scalp in order to prepare her. So rather than sort of throwing all this at her at day one and then just saying, good luck, some of your hair is going to fall out, we actually get flagged in the few days before it hits that threshold dose where we expect for her hair to fall out. Now imagine prostate patients. They can scan their own bladders in a cubicle off the waiting room and actually be told, based on the data, whether they need to drink more water or whether they need to wait longer before treatment. So rather than hauling them in, asking them in front of the rest of the patients in the waiting room if they have drunk enough water or they feel full enough, we can actually allow an automated system to manage that for us. Finally, our threshold for adaptive replans is much lower as auto-segmentation and automated planning allow for the development of new plans in significantly less time. At the treatment unit, we're much more adept at judging the clinical considerations for a replan. And that then leaves planners to spend the majority of their time on complex, unique plans that can't be managed by the system, collaborating more directly with the oncologist and the physicist, as well as likely being paged down to the treatment unit more often. So these are just some of the ideas that I came up with in these sort of blue sky exercises with my therapy colleagues on the treatment unit over a series of days. I'm going to come back to the impact of professionals after I set up sort of the stage for some of the big considerations here. So none of these potential practice changes can happen inside of a bubble. So many of them sound great, but are we prepared to deal with AI's shortcomings or the challenges it raises in society? In short, have we really thought this through? So a common example to show where machines really just can't hold a light to humans is in what appears to be basic common sense to us, but it's the fallibility of rule-based decisions. We might be able to look at these images and clearly discern the breakfast food from the small dog, but actually this is a machine algorithm that actually identified all of these as blueberry muffins. So often when AI gets it wrong, and when you think about it, you can see how AI got this wrong. This is not something a human would ever get wrong other than at sort of a quick glance, but you can see how a machine picking out certain characteristics would lump all of these together. So that's where the input data is not biased in any way. It's the algorithm that is limited. But imagine if the data we were feeding into the system is also biased in some ways. I'm guessing that many of us know what this stands for. It's garbage in, garbage out. And in AI, it applies to the idea that if we feed poor quality data into the system, this speaks to the veracity V, it'll spit out poor quality results. So we tend to think of technology as being immune to a fault that is uniquely assigned to humans, and that's the idea of bias. So I referred to that back in that sort of tongue-in-cheek article at the beginning. It highlights the hypocrisy of worrying about machine bias when humans are fundamentally biased. But the difference is there's another layer when everybody knows that humans have some sort of bias, and we're always sort of on the lookout for it. But there's a general assumption that machines do not have that kind of bias, and that's a trap that we can easily fall into. So what does the data depend on, or the potential for bias depend on? It depends on a number of things. For the data, whose data was fed into the system? It's commonly known that African Americans are less likely to enroll in clinical trials, and that's a historical thing. So if the majority of data fed into the system is that of Caucasians, it can be argued that issues of health equity come in and the bias that this introduces. There are inherent differences in genetics, socioeconomics, and other factors such that the system could serve certain populations better or worse than others if only certain data is fed into a system. The context in which the training data was created is also important. If all the images fed into a system were acquired on, say, a GE scanner, and then that model was then applied and used on a Philips environment, will the nuances of the pixels, the contrast, the Hounsfield units be the same? What if the training data was developed in the context of a specific practice, such as IMRT, and then that model was then tried to use in an environment where we're now treating with VMAT? If we don't know what data was used to train a system, and we may not if it's sort of in a vendor black box, then we don't know the appropriateness of where we can apply it. Lastly, the system is not immune to human bias. In fact, any bias held by those who built the system, meaning they sort of have blinders on, even if it's not intentional, sort of blinders on to the things that they need to consider that lead to bias, then that could end up in the system and ultimately be rolled out across any populations for whom that system is used. So when it comes to the moral pitfalls of AI, there's really no better example than driverless cars. So this example here is a common problem acknowledged by ethicists in this space. Those split-second decisions that humans face when they're trying to acknowledge and avoid an impending accident must actually be programmed into driverless cars. So imagine people sitting around in a boardroom and saying, in each of these situations, which is more appropriate. These are decisions that are made in a split second, and we don't fault most people for the decisions that they make in those moments. But now what if we have the benefit of time and we sit around and try and make the most appropriate decision? So which of these options is better? That the people in the car die, that the people in the crosswalk die, that the dog dies? Who gets to decide this? Again, is it the people, the loved ones of these people? Is it a bunch of people sitting around in a boardroom who are worried about the lawsuits if their car gets into certain accidents? And finally, should it depend? And how do we build that into a system? Were these people in the crosswalk jaywalking, or were they walking legitimately and it's the car that's at fault? So another issue to consider is that of the lack of explainability of AI. So we often talk about AI's black box, that we're unable to track the logic of a machine learning system in reverse to see how it came to a decision. And that's not often intentional. That's not just a proprietary vendor thing. Often these algorithms are built such that it's not possible to discern what factors were used to come to a decision. So by what margin was a certain decision or output determined over another one? Were they actually very close and one just marginally made it better? Or was there actually a clear winner in any decisions? A lot of those kinds of things, as well as what factors were used, what factors were ignored in determining an output, these kinds of things are not known if we're dealing with a black box. So this cartoon likely represents some sort of financial decision. someone was denied a loan or a mortgage, without being able to know why, she can't challenge the decision. She can't appreciate what she needs to address in order to be successful the next time. So imagine a healthcare scenario now. A decision is made to triage your child as being behind another one who appears to be in less distress. Are you more or less comfortable if this is coming from a machine versus if it's coming from a nurse who's standing there in front of your child and still judging that another child needs to go first? Now picture yourself as the healthcare provider in this decision. How do you feel when the system dictates how you should respond in a certain medical scenario? So these are the sort of clinical decision support AI tools, especially if this were to contradict your medical judgment. But it comes from an AI solution that your department has implemented into your workflow to streamline decision making. In such situations, who's accountable to the outcome of the decision made? The vendor of the technology, the employer who purchased it and made you use it, or the provider, you, who acted on that decision? So this comic is a bit tongue-in-cheek, but it's a real topic of discussion right now. Currently, a machine is not a legal entity that can be assigned blame. So someone that relates to that technology in some way would be the one to bear the brunt of any blame if a decision is incorrect, quote unquote. How do we resolve that kind of situation moving forward? So there are some groups who have begun to consider the importance of establishing policy in these areas. Most of these are public groups looking to inform formal policy, not specifically in healthcare, but more broadly. The first is the Universal Guidelines for Artificial Intelligence, and they were released about a year ago. They're looking at such things as the right to transparency of decisions, the right that the final say in any decision be made by a human, such things as protecting privacy, and the one that I think is funny is termination obligation, or the idea that if ever it starts to look like a machine is making decisions without the intention or the guidance of a human, that we shut it down. This is the Montreal Declaration for Responsible AI, sort of a similarly focused initiative, but it takes perhaps a more highbrow perspective on human equity and autonomy. So another potential issue with AI that is perhaps front of mind for many of us as healthcare providers is the professional implications of this kind of technology. As you'll see over the next few minutes, however, this is really only an issue if we see it as being such. It could also be an opportunity. First, there's all sorts of hype in the media about the future of jobs in light of AI. Some of it's more neutral, suggesting that things will change. Some of it is alarmist, warning that we're all going to lose our jobs, including in healthcare. Some reflects more restrained projections, suggestions that will still be necessary, at least for now, and some actually argues that will remain of great relevance, but perhaps in a different capacity. So as we go through some of these examples, consider what you think the impact would be on the jobs of the people who normally are responsible for the roles and work being assumed by the examples, and reflect back on the examples that I gave earlier. So there are a number of stakeholders involved in preparing for an AI-enabled future in healthcare. And while I won't claim that any one is more important than another, much of my work has focused on the Health Professional Association. So that would be groups like the NSAMRT, CAMRT in Ontario, the OIMRS, so the professional associations who are responsible for sort of the entry to practice guidelines, the professional culture, continuing education, and scopes of practice of the profession. My rationale for choosing to focus on the HPAs is the desire to look on the sort of social disruption, or how humans are preparing to interact with the technology so that we aren't what I call banging a square peg, us, into a whole practice which is fundamentally changing shape. The technology is only really as good as the people and system that are built around it. So there's a website out there hosted by the BBC that suggests the likelihood of any given profession being replaced by technology, essentially their risk of automation, or will I lose my job? If we search medical radiographers, which is essentially the British equivalent of medical radiation technologists, what do you think we'll be told? Perhaps surprisingly, there's only a 27% chance that we'll be automated. The system tells us that if our jobs involve negotiation, helping others, or coming up with original ideas, then we're likely safe. So this may be a bit of a sort of short-sighted, fun oversimplification of things, but the fact that it exists is quite interesting. And it's sort of fun to go in there and type in various professions and see what it tells us about them. This actually relates well to some important considerations. So there's a wonderfully relevant analogy that was first articulated in an editorial about 4 years ago now by Dr. Brian Hodges, and he's the VP of Education for the University Health Network in Toronto. So he presented the story of Dorothy Vaughan, played by Octavia Spencer in the movie Hidden Figures. She was one of the many African-American scientists who manually completed very complex calculations for NASA in the race to the moon in the 1960s. So here she is. She witnessed the arrival of an IBM computer. So there it is there. And as she took the initiative of reading the operator's manual, she realized that the need for human computers would soon fade. So she saw the writing on the wall, and rather than just sort of rolling over and saying, oh, woe is me, I'm out of a job, she rallied her colleagues and arranged for them all to attend night school. So by the time the IBMs really took hold, the women had positioned themselves as computer programmers. So they recognized that their jobs were going to be replaced by technology, and they changed their jobs to be relevant. So Dr. Hodges uses this analogy to discuss the plight of healthcare providers faced with AI. He's concerned on the whole that healthcare providers or professions are not as forward-thinking as Dorothy Vaughan. So there's an interesting way to look at how our professions need to maintain their relevance in future practice. It's the idea of the missing middle. If you assume that there are some things that are always going to be better done by humans or always better done by machines, there's still this space in the middle where humans and machines are complementary to each other or can augment each other. And it's this space that could be really interesting for us to explore. So this concept is the central theme of one of the best books that I've read on AI, and I've read a few of them, published about 2 years ago by the Harvard Business Review, and it's entitled, Human and Machine. So some professions have begun to acknowledge that they need to be a little more like Dorothy Vaughan, be proactive in positioning themselves to be equipped and essential in an AI-enabled world. A few have published formal calls to action in the form of white papers or position statements to their memberships, as well as to external stakeholders that present their position on AI, what they see as their role within it, and their approach to preparing for it. So here's one for pharmacy. And this is one for radiology, and the CAR is perhaps leading the charge in these. It's actually put out 3 or 4 white papers now, and they're quite respected. And finally, this is one in radiation oncology by Astro. And I know that the CMRT, I'm on an AI task force with the CMRT, and they're working on a position statement in this space as well. So these are often written by formal task forces that are struck by professional groups to lead the charge in preparing for AI. So each of these, and here's an example actually, while the CMRT has not yet put out a position statement, it did have a special issue of JMRS just last year that I guest edited that had a number of MRTs and others reflecting on artificial intelligence in our profession, and a lot of that is going to be used to inform the position statement. But what a lot of these position statements or white papers have in common is these 4 broad considerations: the engagement needed by the profession in conversations around this space, the education needed for their members and for their patients, the research efforts that are needed to inform or to ensure that future practice is evidence-based, and finally, advocacy, the education needed by the profession to external stakeholders about how the profession envisions itself in this future practice. So things are happening. We're starting to think about AI, perhaps more than just talk about it. But now, how do we take action, and how do each of us as therapists at the front lines or at the point of care, as educators, managers, researchers, how do we ensure that our profession is ideally positioned to be vital to AI practice and to provide still the highest quality of care to our patients? So the biggest thing I'd suggest is that we need to change our thinking and see what we currently see sometimes to be a risk or the fear of losing our jobs, and instead see it as an opportunity. Where we're in denial or quick to dismiss the value of AI or be afraid for our jobs, we need to get our heads out of the sand and start taking ownership of what's coming. Things are not going to be the same for many professionals, and evolution can be healthy. If you were a radiologist or pathologist and you looked at this article, it would make you nervous, a fundamental change in the focus of your job. But there's such potential for value in this idea, the idea that technology will manage much of the pattern recognition and the rule-based stuff in our jobs and free us up to deal with managing what the machine spits out at us and doing that in the best interest of the patient, that it's those pathologists or radiologists who see a heading like this and don't dismiss it or run for the hills or take early retirement, those ones are going to be most successful in an AI-enabled world. Now, what about this heading? So I'll tell you that when this came out in about 2014, Dr. Sharp, who wrote one of the point counterpoint, he was a medical physicist at Princess Margaret. He steered clear of the planning area, so the entire 1B floor for a few days as this article started circulating amongst the planners. Nowhere in this article does it actually state that planners will not be necessary, but it does suggest that much of what they are currently doing or what they were currently doing 6 years ago would not be necessary. Would be offloaded to technology, and that they'd be doing something else, something more complex, something that better used their skills, and that the relative weight of their various roles would now shift and they would be applying their expertise in a different way. And so the message here is that we need to avoid holding too tight to a practice that will soon become irrelevant, trying to jam a square peg into a round hole when it's not going to do us any service. So our practice today certainly isn't the same as when technicians first began to manipulate those cobalt sources to target cancer centers all those years ago. And change may happen a bit more rapidly over the coming years, but it will still serve us best if we embrace it, look ahead to it, and prepare for it. So how do we do that? Essentially in the same ways that it's argued in some of the white papers that I'd encourage you to read. Even the ones focusing on other professions often have value in some of these same messages. We want a seat at the table in defining how AI can most effectively and responsibly be incorporated into practice. Where will it benefit practice? Where should it not replace a human? Are we equipped to recognize where it's failed? Are we protected when it does fail? These are all conversations that would benefit from our insight. So in considering what our future roles might look like, we need to make sure that we stay true to the essence of our profession. We are not, for example, going to start offering legal advice or drive our patients to their and from their appointments. These other things that are completely not relevant to the core culture, ethics, values, and competencies that we have as radiation therapists. So all that to say that if we remain relevant to future practice and viable as a profession, we need to be honest with ourselves. What aspects of our current roles are replaceable? What things can we let go of? What roles are we best positioned to advocate against transition to machines? So we know best when certain things may not be appropriate to be offloaded. In what aspects of our current work can machines augment what we do? In what aspects of our current work can we complement the machines? And so these two are about the idea of that missing middle. And finally, are we ultimately prioritizing the quality of care that we provide over our fear of the future viability of the profession or of our jobs, essentially? So always think back to that one. And finally, that's the end. I'm sorry that I couldn't be available to take questions or engage in a broader discussion after drinks as we normally might at a conference. But that's the reality of these times. Feel free to email me, go out, find those white papers, take a read, look out for what the CMRT is going to be engaging in the coming months, because this is an important space and it's incumbent on all of us to sort of get those basic skills and competencies so that we can help to judge what's appropriate for our profession and for our patients. So thank you very much and enjoy the rest of your education day. Take care.